Hi everyone, my name is Dr. Cristina Cubillo Santos. Welcome back to my channel. If you're new here, please click like and subscribe. Today's guest is Dr. Iris. Iris is a long-term colleague of mine and a friend, and we've known each other for many, many years. Iris is actually someone who has a movement background, so she comes from a dance background. We used to teach aerial yoga together. She has a master's in neuroscience, and she's a doctor of physical therapy. So she has a really, really awesome expertise in her tool belt when it comes to working with people. And today's topic is talking about the health of pelvic floor, because a lot of people suffer from pelvic floor dysfunction, and it's not a topic that's talked about a lot out there in the public realm. So Iris, welcome. Thank you so much for joining me today.
Thanks for having me, Christina. It's lovely to see you and to be here with you.
Yeah. Awesome. So Iris, as I mentioned, you have been a mover for many, many years, right? So you've been exposed to working with people in many different ways. And going from neuroscience to now being a doctor of physical therapy and specializing in pelvic floor dysfunction, can you tell the audience a little bit about maybe even why the pelvic floor specialty in the first place? And then what are some of the common dysfunctions that you see in your practice or in the clinic that you're currently working
in? So to answer your first question, like my kind of background in movement, dance, I have a background also in martial arts that I've been growing over the past 4 years, in karate, and recently boxing and jiu-jitsu and Brazilian jiu-jitsu and stuff. So I've been continuing to expand my movement practice. And then from the neuroscience aspect, where my thesis was looking at the role of emotion regulation in our ability to learn motor movement and motor control, and then into physical therapy, which is treating pain and dysfunction in individuals through the musculoskeletal system, through bones, muscle, tendon, and through movement practice. So those kind of, like, a lot of times people are like, how did you go from dancing to neuroscience to PT? And I'm like, well, they're actually all really connected. They're all rooted in movement. They're all rooted in self-exploration and awareness and expanding that awareness. So that's kind of a little bit of why I ended up where I am. I personally have had pelvic floor dysfunction. I had stress urinary incontinence when I was when I was 20, and I was studying abroad in Israel. I didn't know it was an actual problem. I didn't go to a pelvic floor specialist for this problem. I actually had a hip issue, like a sacroiliac joint dysfunction, and I was going to a regular PT, and the PT did dry needling to my adductors and noticed that the tension of my adductors was going deeper into my pelvic floor, and he referred me out to a pelvic floor therapist. I had no idea what it was. I didn't never had I walk in, I don't know what to expect. I had a history of constipation, and while during that time when I was in Israel, I also had gotten a colonoscopy, and because I had like a bunch of digestive issues, and turns out I had pelvic floor dysfunction. I had a hypertonic pelvic floor that resulted in, when I would jump, and I was dancing abroad, so when I would jump, cough, sneeze, laugh, I would leak a little. And it ended up, once I was getting that treated and learning to breathe, turns out I wasn't breathing and managing the pressures of my abdomen properly while I was dancing. And so that's kind of like the introduction that I had to pelvic floor and how I found my way here. I wasn't planning on going into pelvic floor, but turns out it's a passion of mine. So it's where I ended up in the end. So I started with it, and then I am now ending with it. So that's kind of where I find myself now.
That's amazing how it all came full circle in a way, right? And also the intricacy of the human body and that interconnectedness, right? Because as a Chinese medicine practitioner, we always look at the body as a whole. And sometimes in Western medical model, we go into that reductionist model. So it's like you go to the specialist for this, for that, for that. However, when we work together, when we understand when to refer out, miracles do happen, right? And so your journey in your own healing brought you to where you are today, which is magnificent, because you can then help a lot of people deal with something that's a lot more common than we think. And that is that pelvic floor, I don't know if I can say dysfunction, but in a way, because of your neuroscience background and that connection to the nervous system, right? The tension, the upregulation of the nervous system causing actually tightness in the pelvic floor. So can you talk to the audience a little bit about that nervous system connection to the, I guess, tension in the pelvic floor musculature, and how that can exhibit, in certain issues, whether it's incontinence or other things, as you mentioned in your own case?
Yeah. So to kind of backtrack a little bit, I will kind of clarify that pelvic floor dysfunction, we treat a lot of different things. So tension and hypertonicity of the muscles being tight, is or weak is one thing that we treat. It's not the only thing that we treat, and that is kind of a character, but not a cause, always the cause. Like having a tight pelvic floor isn't always the cause of incontinence. There's a lot of different reasons, like having a bladder or bowel dysfunction, whether it be incontinence or constipation or diarrhea, or like when we talk about incontinence is leakage. So that could be fecal leakage or vaginal, like
Urinary
leakage. But you can have leakage not because of a muscle problem, but because it's a bladder to brain communication issue too. And that the bladder, you could be leaking urine because you're constipated, because you have pressure. The rectum sits behind, if it's a female, like you have a rectum, and then you have the uterus and vagina, and then you have the bladder. And if you're constipated and the rectum is full, it's going to put pressures on the bladder. So when it comes to why people might have pelvic floor dysfunction, tension is definitely part of it. It just depends on what we're talking about. It's hard. It always comes back to, it depends.
Of course. Yeah. Just as any medicine, it's like, well, it depends, right? What came first? Right.
Yeah. And also like you've seen, like after giving birth, like their incontinence is something, and that's just because everything is so rearranged and stretched, and it could not even be about tightness. It could be completely about over lengthening and weakness too.
Absolutely. No, that's great to point, because, we definitely don't want to make it seem as if it's, oh, this is one reason, right? And the only reason, but there are so many layers to it, as well as breathing, right? You mentioned breathing as one of really big components to it. So what can you speak to the breath connection to the pelvic floor and just overall, right? Sometimes, and you are a yoga practitioner and a teacher, so sometimes you hear the cues in classes like use the diaphragmatic breathing, expand your abdomen, and like sometimes flowery language. But what does that mean? Is that good for everyone? Should there be variety, right? And even Kegel exercises, right? We instruct people to like contract their pelvic floor. What if someone's pelvic floor is already too tight? Should they be contracting more, right? So it's just so many layers to even discuss, but just more on a superficial layer so people can understand at least the basics of breathing and pelvic floor function.
Yeah, so I'll kind of walk you through when I evaluate a patient. One of the things that we look at is their breathing, is how do they breathe at neutral, when you're just like looking at them. Usually when they're talking, I'm paying attention to where they're breathing. When I'm taking a subjective and I'm just asking the questions and listening to their story, I'll start at that point looking at how they're breathing. Are they breathing from their chest? Are they hunched over? What is their posture like? How are they sitting? How are they presenting their body and placing, and what positions are they placing their body in? And then I'll have them lie on their back and just take a couple deep breaths and look at where the breath is moving in their body. And based on that, I make a decision. So often what we see, and this isn't all the time, so sometimes I'll have people come in with complete, very serious problems and dysfunctions, and they can move their stomach so well that I might look at them and be like, you're diaphragmatic breathing. Like, you are letting your belly expand, you are letting your ribs expand, and there's a lot of inhalation, but maybe their exhalation is forceful and over effortful, like so much effort in their breathing, like they're over working their diaphragm to the point where it might not be working with other things. It's about coordination and collaboration within the body too. So we're kind of like in an evaluation, just to kind of go back, I think of breathing as the baseline. How is someone breathing tells you a lot about how they move in their day-to-day. How do they support their body? How do they engage with the world? Because if they're breathing breathing is purely about pressure management, and the pelvic floor and the diaphragm work together like a piston. So as the diaphragm drops, pelvic floor drops. As diaphragm lifts, pelvic floor lifts. And it kind of does this very subtle up and down. And unless you have a dysfunction in that area, you rarely notice that you even have a pelvic floor. So the pelvic floor is like any other muscle, like your bicep or your tricep. You can voluntarily contract it and you can voluntarily relax it. You can also actively lengthen it. That's what happens when you try to push a stool out, or when you put over pressure and you exhale and you're pushing pee out really fast when you're trying to urinate. So there's a relationship between pelvic floor and diaphragm, which is why it's so important for us to look at it as pelvic floor PTs. And in general, allowing the abdomen to move with breathing is really, really valuable. But you made a really good point about variety. And the idea is that diaphragmatic breathing isn't the best type of breathing. And it really, and I know that there tends to be a lot of like focus on diaphragmatic breathing, but the most important thing is just when my patients come in and they're breathing a certain way, I go, okay, you're breathing this way, but you're still in PT. You've just arrived at PT. So if you're breathing this way and you've arrived at PT, something that you're doing isn't working for you. So let's try something new. So usually what we do in the first couple sessions is experiment. Are they able to breathe into their ribs? Are they able to breathe into their chest? Are they able to brace their abdomen and breathe into their chest and ribs and not breathe into their belly? Are they able to breathe into their belly and allow pelvic floor to move? Or can they just breathe into their belly without pelvic floor moving? And it's about the variety, because the demands that are placed on us by our environment changes and requires a different response every single time. So if we always have one strategy, if we only know how to pick up a pen this way, then I can't hold it this way. I can't hold it, like, there are so many different ways that I should be able to hold a pencil. It's the same thing with breathing.
Yeah. So you're really, in a way, you are rewiring the nervous system as well, right, in your work to help your patients achieve better results, because what they're currently doing is clearly not serving their body, right? So there is that nervous system rewiring component in your work.
Yeah, there definitely is a nervous system component. I mean, even diaphragmatic breathing, a lower abdominal, deep abdominal breathing does downregulate the nervous system. And when we're upregulated, that's high stress, if you think of like a chest breather, you're like, that's hyperventilation. You can feel it in your body when you try and imitate certain postures, just like power postures. Like they've done research about certain postures. If you stand with your arms like a Superman or Superwoman pose, like with your elbows out to the sides, if you stand with really open chest posture, that can also boost confidence. It can also increase your lung span, the space for your lungs to breathe in, so you get more oxygen into your body. There's so much to how we move that affects our nervous system, and how our nervous system affects the way we move. You can't, and so oftentimes what I try to do with my patients is just say, let's try something different. You're on a 4-lane highway. Your chest breathing is a 4-lane highway with 0 traffic. And your diaphragmatic breathing is a 1-lane highway with construction. So we're trying to make them a little more even and accessible. It's about accessibility.
Yeah, that's awesome. And so in your experience, how long do you usually or how long does it take to see results in patients, or some type of release, right? Because when we think of physical therapy, and even in Chinese medicine, people are, so how many sessions, right? Obviously, everything is individual, it depends. But is it something where it's like, okay, well, we usually do at least 10 sessions, etc. And like you mentioned in our private conversation, pelvic floor therapy is something that is longer than half an hour. It's not your typical physical therapy session, right?
Yeah. So in my practice where I work, Beyond Basics Physical Therapy, we do hour-long sessions. That gives us a lot of time to talk, to look at the subtleties of breathing, to introspect and question as to why things are the way they are. In a half hour, you don't really have that much time to explore that deeply, the subtleties of our bodies. And for those of your audience that doesn't know what the pelvic floor is, the pelvic floor are all the muscles that are at the base of your pelvis that support your sexual organs and your digestive organs. It keeps poop in and pee in when you want to keep it in. It keeps poo and pee out. It gets it out when you want to get it out, and also helps with sexual function. So pleasure, pain, and so we address pain with sex. We address erectile dysfunction. And so forth. We also work with prolapse, and when things become lax and heavy, and there starts to be laxity in that area. So the duration of a session is an hour, and it'll vary whether we see someone once a week or twice a week. Typically I like to start twice a week, but most of my patients I recommend once a week, because we also need time. These are subtle changes. And you're not if you've been breathing a certain way, like use breath for an example. If you've been breathing a certain way, they come to me when they're in their mid-30s. They've been breathing for 30-something years a certain way. I'm not going to change that in 2 nights and see a change. So I have to give a little bit more time in between sessions to really see change. I also say that the duration of someone's care varies based on how consistent they are with their with the strategies and changes that we're trying to implement.
So homework, right?
Yeah, our homework, the home exercise program. Often I start out the homework by starting with awareness exercises, things that are very easily implemented into their day-to-day, because those things, when you can implement them more and more and more, they're more effective. It's about practice. And then the last is kind of just knowing pelvic floor dysfunction because of its relationship to the nervous system, and also the psychosocial aspect associated with that area. Like you have a hurt elbow, you're like, oh, my elbow hurts, the whole world can see it. But if you're incontinent, you can't, like maybe you can still go to that wedding with a hurt elbow, But if you're peeing yourself every 30 minutes and you have to run to the bathroom, maybe that movie on a Thursday night isn't going to be an option. And it starts affecting, it's a little more, it affects someone's day-to-day routine and ability to engage with the world a little bit more intensely. So its relationship to how that also affects you psychosocially is also greater. So considering all of that, we usually say 3 months in a easier, more simple, once to twice a week program where someone is doing their homework every day and implementing all the strategies and really focusing, to maybe 6 months or even like greater, to a year. And then there's also the reality that chronic pelvic pain is chronic. And it's not about, just like low back pain, we see that with low back pain, we're not going to get rid of your low back pain. What we will do as PTs is we're going to reduce the number of flares that you have, and then we're going to make the duration of the actual flare less. So maybe the first time you hurt your back, you're out of work for a week and a half. And then that would happen every 2 to 3 months. With training with PT, that becomes every 6 months, only a week long. And then it becomes 3 days every once or twice a year. Yeah. And like, so we're really trying to not look at healing as a moving from A to B rather than going back to A. If that makes sense. It's a process that we're acknowledging where the person was. They had this incident that caused pelvic floor dysfunction, and then we're moving forward from there, and we're not trying to go back to what they were, because now they're aware of their body in ways that they never were aware.
Absolutely. Yeah. I love that you said that, because that's really my approach as well with my patients and clients. You know, it's like minimum of 3 months. Of course, you'll get better with a few treatments. Of course, there will be some change, but you also need to do the work as an individual outside of our sessions together. You need to step into your own understanding of who you are in the world, how you operate. So you take into consideration the whole person and who they are, right? So I love that even in physical therapy, you know, people probably wouldn't make that assumption that you look at all those aspects of a person and allow them to view themselves in a different way, as opposed to, hey, I was good before. 5 years ago, I was good. I want to be that person again. It's like, no, you'll be better actually, because now you'll understand yourself a lot more. So that's amazing, Iris. Thank you so much for sharing all of that. And just kind of to wrap up, so you already mentioned, you start with an assessment when someone comes into the clinic. And what can a person who, like you said, you never experienced pelvic floor therapy before, you went into a treatment for yourself, what can a person who has no idea what to expect from a session, okay, they'll have to disrobe. What is a session like for someone who has no idea what to expect?
Yeah, so there are 3 different components to a pelvic floor exam, like a pelvic floor PT exam.
Yeah.
So we usually structure it, and I explain it. We're going to talk a little bit, like a patient walks in, they've never been to pelvic floor PT, maybe they've never been to PT before in their life. And so I'll sit with them and I'll say, okay, we're going to talk for a little while. I'm going to hear your story. And then we'll talk about what the pelvic floor is. What do I think is going on based on what they told me? But it's my working hypothesis, and it's always a working hypothesis. There are no
definites.
It's just, okay, this is what we see. These are patterns. This is what the research tells us. This is what I know about the body, and we'll see. This is what I'm curious, and this is what I'm going to be going. I'm starting to create my little roadmap based on what they told me. And then from there, we go into the examination portion where like any other physical therapist, I'm going to look at how they sit, how they stand, how they squat, how they do a single leg squat. I'm going to look at their hip strength, their leg strength, their core strength, their automatic core stability. I look at their breathing. I look at very basic, just how do they move in their day-to-day life. And then we go, that's like the first part of the examination. And then we have an external pelvic floor examination where I'll have the patient take everything off from the waist down. They'll have themselves covered with a sheet. I'll step out of the room for that. They'll come in, and then we look at the pelvic floor muscles directly. So whether that means the male lifting his scrotum and penis upwards, so we can look at the perineal body and the anal opening, and then, or the female, they'll just have their knees bent, and we look at those external muscles. And we also look at tissue integrity. We look at where the muscle's located relative to the other. We look for hypertonicity, and then we also look for tenderness. So with a gloved hand, we'll press on the muscles and feel like, are these muscles tight? Are they tender to the touch? Just like if you were to press on like any trigger point in the shoulder, oh, that hurts, or you had some knee pain, and the PT would be touching the knee to kind of feel where it hurts. And then we might do an internal examination depending on the patient's comfort level. All of these components of the examination, just to say, are done with continued acquired consent. So even as we move through the examination, is this okay? This is the next, we're moving on to the next section. Is this okay? And I've had patients who I have treated for 3 or 4 sessions that I never looked at their pelvic floor directly. So I've worked with their urinary urgency without even taking a look at their pelvic floor. And we've made lots of gains without even looking at the pelvic floor directly. So each of these are valuable ways of looking at pelvic floor, and they give us different information. So we've done the physical exam of just how they move. We've done the external, looking how the muscles might be tender, how do the tissues look, how do they coordinate the muscles, how do they contract, how do they relax, how do they lengthen the muscles actively, are they able to lengthen? And then the last thing would be that internal examination where with a gloved finger, a gloved hand, one finger, and a little bit of lubricant, a water-based lubricant, we either enter vaginally or rectally, and look at the strength of the contraction, the quality of the contraction. We look at the deeper layers of the pelvic floor muscles and their tone, and if those are tender, and work from there. So that's kind of the information that we get. And those are the 3 main components of a pelvic floor PT examination if you were to come in, all of which are valuable, none of which are a requirement to come to pelvic floor PT. So you can always say no to any part of the exam during the session prior to, and that's totally okay.
That's awesome. I really hope that this sheds some light to the pelvic floor, which is a depth that is in the darkness a lot, right?
Yes, definitely.
Yeah, so really with this information and this conversation, my wish is for people to maybe approach this topic with a little more ease and not feel fear, and if there is certain issues that a person may be going through, that there is a way to address that, because even in Chinese medicine, people come to us and they say, oh, I've been dealing with the urinary incontinence for years. And it's like, why? Right? So, or low back pain, or even sacroiliac joint dysfunction, and not knowing the true cause, especially if there was no real injury, right? Or an accident that caused it.
Yeah, it's definitely important to know that pelvic floor PT exists, because just like if you were to have back pain, you go to physical therapy as conservative management prior to getting surgery or doing medications and all these things. It's like, give pelvic floor PT a try if you're chronically constipated, because if it's not the answer, then it's not the answer. There's another answer. We're the first ones to say, you don't have a pelvic floor dysfunction. But oftentimes when you're in pain or when you have chronic issues in the abdomen and the pelvic floor area, whether it be due to the musculoskeletal issue from its origin, often it can help with pain management and it can help with symptom management, in addition to the other treatments that you might be exploring.
Great. And so, Dr. Iris, where can people find you? You are working currently in New York City, right? You're at a particular clinic. Feel free to share that information so people know how to find you if they have the need for that.
Yeah, I'm working at a clinic called Beyond Basics Physical Therapy. It's in Midtown Manhattan, right outside of Grand Central, right across the street. So come visit me or any of the therapists at our clinic. Find a pelvic floor clinic in the area that you just to explore. It's a wonderful opportunity to just learn about your body, and explore your body a little deeper than you ever might have had before. Yeah.
Amazing. Thank you so much for your time. Thanks for catching up with me. It's been a pleasure learning all
lovely.
these tidbits. And we'll talk to you soon.
Yeah.
Take care.
Okay. Bye.
Bye.